Hi guys, today our session is about glomerular filtration rate and renal blood flow. This is the third session of renal physiology series. Today we are going to talk about the determinants of the glomerular filtration rate and the renal blood flow and the physiological control of GFR and the renal blood flow. So first we are going to talk about the determinants of the glomerular filtration rate. What are the determinants of GFR? So usually GFR depends on net filtration pressure and the glomerular capillary filtration coefficient. So the net filtration pressure means the sum of hydrostatic and colloid osmotic forces across the glomerular membrane. So we calculate glomerular filtration rate by when we multiply Kf by net filtration pressure. Kf means the glomerular capillary filtration coefficient. It's a fixed value. So net filtration pressure, as I told you previously, net filtration pressure is the sum of hydrostatic and oncotic forces. So what are the forces in favor? They are in net filtration pressure. When we talk about the hydrostatic and oncotic forces, there are forces which favor the filtration and the forces which are opposing filtration. Okay, so what are the forces favoring filtration? They are the glomerular hydrostatic pressure and the Bowman's capsule colloid osmotic pressure. Usually we calculate Bowman's capsule colloid osmotic pressure as 0. What are the forces opposing filtration? They are the Bowman's capsule hydrostatic pressure and the glomerular capillary colloid osmotic pressure. So, how do we calculate the glomerular filtration by these values? So, we have to multiply the Kf, glomerular capillary filtration coefficient, by the value which we get when we subtract Pb, hydrostatic pressure in Bowman's capsule, and the 5G, the colloid osmotic pressure of the glomerular capillary plasma protein, and when we subtract those two values from the glomerular hydrostatic pressure, and we add the amount to the 5B, which is the colloid osmotic pressure of proteins in Bowman's capsule. So this is an example to calculate the net filtration pressure. So try it and get the answer. Okay. Just simple. You have to add these values to the equation and get the value net filtration pressure. Okay. The glomerular filtration coefficient. This is represents the hydraulic conductivity and the surface area. So we can't measure directly the Kf. So we usually get the estimated value. This equation for estimated value is we have to divide the glomerular filtration rate by net filtration pressure. Okay. So because total glomerular filtration for both kidneys usually about 125 milliliter per minute. Okay. So the net filtration pressure get 10 mercury millimeter. So the value is this value. Usually it's 400 times high as the Kf of most other capillary systems of body. So this allows a rapid filtration at the kidneys. So what is the clinical relevance of Kf? Why do we have to know about the glomerular capillary filtration coefficient? When there is an increased Kf value. So when there is increased Kf value, usually there is increased glomerular filtration rate. And when there is decreased Kf value, there is reduced glomerular filtration rate. So the Kf value can be reduced by the uncontrolled hypertension, diabetes mellitus. Because in these conditions there can be thickened glomerular basement membrane, reduced surface area, loss of functioning capillaries. These can lead to a reduced value of Kf. So we are going to talk about the Bowman's capsule hydrostatic pressure. So the normal value is about 18 mm per mercury. When the Bowman's capsule hydrostatic pressure increases, it inversely proportionate. So when the value increases, glomerular filtration rate decreases. So what are the causes which can increase the Bowman's capsule hydrostatic pressure, which can lead to reduced GFR? They are the urinary tract obstruction. So the urinary tract obstruction can be caused by stones, tumors, enlarged prostate. If we did not intervene, it can lead to hydronephrosis. Okay. So next we are going to talk about the glomerular capillary oncotic pressure. So this rises as the plasma protein concentrate across capillaries. Usually at the afferent end, it is about 28 mm per mercury, and the efferent end it is about 36. So when we get the average value, it is about 32 mercury millimeters. So what are the factors which affect the glomerular capillary oncotic pressure? So they are the factors which affects are arterial plasma protein concentration and the filtration fraction. So we get the filtration fraction by dividing glomerular filtration rate by the renal plasma flow. So for the glomerular capillary oncotic pressure, GFR renal plasma flow also affect as the filtration fact also affecting that. Okay. So what is the effect of renal blood flow? When there is increased renal blood flow, the protein concentration is less. So it leads to decreased 5G, which is the glomerular capillary colloid osmotic pressure, and thus it increases the glomerular filtration rate. And the opposite, when there is decreased renal blood flow, it increases the glomerular capillary colloid osmotic pressure. So the opposite happens and the GFR value decreases. So the renal blood flow regulates the glomerular filtration rate independently of the PG, which means the glomerular hydrostatic pressure. Okay. What is the role of glomerular hydrostatic pressure? When we talk about the normal value, it is usually about 60 mercury millimeters. So this is the primary mechanism of physiological regulation of glomerular filtration rate. Okay, when the glomerular hydrostatic pressure increases, it also increases the glomerular filtration rate, and when the glomerular hydrostatic pressure decreases, it decreases the glomerular filtration rate. So this is the primary mechanism. What are the determinants of glomerular hydrostatic pressure? So they are arterial pressure, afferent arterial resistance, and the efferent arterial resistance. So when there is increased arterial pressure, so it tends to increase the glomerular hydrostatic pressure. So it can therefore there is increased GFR. At the afferent arteriole, when there is afferent arterial constriction, it leads to glomerular hydrostatic pressure decreasing. So it decreases the glomerular filtration rate. And the opposite, when there is dilatation at the afferent arteriole end, it increases the glomerular hydrostatic pressure. So thus it increases the glomerular filtration rate. At the efferent arteriole, when there is mild constriction in the efferent arteriole, there is increased glomerular hydrostatic pressure. So there is a slight increase of glomerular filtration rate. And when there is severe constriction, it can increase the filtration fraction and colloid osmotic pressure. So the net glomerular filtration can be decreased. So there is biphasic effect at efferent arterioles. So in mild constrictions, GFR is increased, but when there is severe constrictions, GFR is decreased. Okay. So the changes are different at arterial end and efferent arterial end and afferent arterial ends. So this is as this can be confusing, I made a quick summary. So, and when there is a constriction and afferent rate, so there is decreased GFR. When there is efferent constriction, in modest constriction, it can increase the GFR, but when there is severe constriction, it can decrease the GFR. So the effect depends on the balance between increased hydrostatic pressure and the increased colloid osmotic pressure. So now we are going to talk about our second content, which is the glomerular filtration rate regulation and the renal blood flow. So when we talk about kidneys usually receive about 1100 milliliter per minute cardiac output. So it is about 22% of cardiac output of the body. So the kidney weight, usually kidney weight around 0.4 percentage of body weight, but when we compare to the body weight, it comparatively receives a high blood flow to the kidney, about 22%. Why do that get such an increased amount of cardiac output? Because we have to deliver nutrition and remove waste, and we have to supply plasma for filtration. Okay. When we talk about renal oxygen consumption, kidneys consume twice as oxygen consumption at the brain, and the blood flow is about 7 times more than the brain flow. So this oxygen consumption is linked to sodium plus absorption. When there is decreased glomerular filtration rate, decreased sodium plus is filtered. So the amount of reabsorbed sodium is less. So the oxygen consumption is also decreased. If the GFR ceases, oxygen usage is about 25% of normal, only for the basal needs. So what are the determinants of renal blood flow? When we calculate the renal blood flow, when we extract renal artery pressure, renal vein pressure, extract from the renal artery pressure, and we divided it from the renal vascular resistance. When we calculate, normal renal vein pressure is about 3 to 4 mercury millimeters. So this resistance mainly in interlobular arteries, afferent arterioles and efferent arterioles. So how to control the renal blood flow? So it is usually controlled by sympathetic nervous system, hormones and intrinsic renal mechanisms. Okay. Now we're going to talk about the autoregulation of renal blood flow and the glomerular filtration rate. Usually body maintain constant renal blood flow and glomerular filtration despite the blood pressure fluctuations. Okay, so these mechanisms are intrinsic to kidneys. They are not controlled by outer extrinsic mechanisms. So the intrinsic mechanisms like myogenic response, tubular-glomerular feedbacks, these maintain the constant flow and GFR despite these blood pressure changes. So when we talk about the renal blood flow, regional renal blood flow, usually cortex receives the most of the renal blood flow, and the medulla, vas recta region only receive 1 to 2% of renal blood flow. And this vas recta is important for countercurrent exchange and formation of concentrated urine. So now we are going to talk about the physiological control of glomerular filtration rate. So what are the key determinants of physiological control of GFR? So there are variable factors. The variable factors are glomerular hydrostatic pressure, glomerular colloid osmotic pressure, and this is influenced by sympathetic nervous system, hormones and auto acid, and intrinsic renal feedback mechanisms. So the sympathetic nervous system. So strong activation of the sympathetic nervous system, it can lead to constriction of afferent and efferent arteriole. So this leads to decreased renal blood flow and decreased GFR. And when there is mild to moderate activation of sympathetic nervous system, there is minimal effect. This is important during acute stress like hemorrhage, ischemia, defense reactions. So what are the hormones that hormones and autocoils? They are vasoconstrictions. Vasoconstrictions usually decrease the glomerular filtration rate. They are norepinephrine, epinephrine and endothelin. What are the vasodilators? Vasodilators increase the glomerular filtration rates. So they are prostaglandin, bradykinin and nitric oxide. Prostaglandins are PGE21 and PGI2. So this is a very important hormone. So angiotensin 2. This is the preferential efferent arterial. It causes preferential efferent arterial constriction. And this angiotensin 2 maintain glomerular filtration rate during low sodium intake, hypertension or hypovolemia. So when there is increased filtration fraction, it can lead to increased tubular reabsorption of sodium and water. So when we give ACE inhibitors or ARB, angioreceptive blockers, this decrease GFR. When there is decreased GFR in renal artery stenosis. When there is renal artery stenosis, the arteries, the lumen get constricted and so the GFR is reduced. So we have to give angiotensin 2 blockers like ACE inhibitors and angiotensin ARB, angiotensin receptor blockers to maintain the GFR. So the nitric oxide and prostaglandin. Nitric oxide, it maintains the basal vasodilation, and the inhibition of nitric oxide leads to increased resistance and thus it decreases glomerular filtration rate. And the prostaglandin is the buffer vasoconstriction, sympathetic effects of sympathetic nervous system and angiotensin 2. So the NSAIDs usually blocks the prostaglandin, so they decrease the glomerular filtration rate, especially in hypovolemia, post-surgery situations. So the autoregulation of glomerular filtration rate and the renal blood flow. So there is a maintenance of stable glomerular filtration rate. It's about 75 to 160 mercury millimeter. So this prevents large swings in urine output. So what are the mechanisms that maintain this? They are the tubular glomerular feedback and the myogenic response. Tubular glomerular feedback. So the macula densa senses sodium chloride delivery and it regulates arterioles. So when there is decreased sodium chloride at macula densa, at the afferent dilation happens and there is increased GFR. So the increased renin and increased angiotensin 2 lead to afferent constriction and increased GFR. So when there is increased sodium chloride at macula dense, the opposite of above happens. So the myogenic mechanism. Afferent arterial responds to stress. When there is increased blood pressure can lead to contractions. So this prevents transmission of increased pressure to the glomerular capillaries. So this mechanism, myogenic mechanisms, helps to protect kidney from hypertension-induced damage. So what are the other modifiers? They are high protein intake. High protein intake lead to increased glomerular filtration rate and renal blood flow via TGF because this can happen due to sodium plus reabsorption with amino acid. The hyperglycemia. In diabetes, there is hyperglycemia, increased blood sugar level values. So when hyperglycemia in similar mechanisms, it can increase the glomerular filtration rate and this can contribute to glomerular injury. And when there is tubular injury from toxins, drugs, it can lead to decreased reabsorption. So it increases sodium chloride at macula densa and it lead to afferent constriction, and thus it decreases the pulmonary filtration rate. So this brings us to the end of today's session. If you have any question, you can send me the question and I send the answers. Okay, thank you.